Hello, I am Dr. Adarsh Choudhary. I am the chairman of the Department of Gastrointestinal Surgery and Bariatric Surgery at Medanta City Hospital in Gurgaon. It's a great pleasure interacting with my colleagues from the Northeast, Dr. Suraj, who's a gastroenterologist, and Dr. Meron, who's a GI a surgeon. And it's a great pleasure talking to my friends. And the aim of this conversation is to understand what is happening in the scenario of gastrointestinal surgery, especially with reference to the Northeast. Am I right, Dr. Suraj and Dr. Merin?
Yes.
Can you please
Absolutely.
introduce yourself, both of you?
So I basically did my DM from AIMS, New Delhi. And then I also did 2 fellowships from Harvard, one in the field of liver disease and one in advanced endoscopy. And I have special interest in image enhanced endoscopy in third space.
Wow.
So recently I completed my training from this one, from Tokyo, Japan.
Okay.
I'm also involved in making all these guidelines in upper GI standardization.
Fantastic. What a pleasure.
Yeah,
You are
yeah.
such an accomplished gastroenterologist player. And Dr. Merin, what about you?
It's such a pleasure to be with, I think I should say my seniors. I did my MS from Colorectal from Kerala. After that, I have done my fellow and GI HPB oncology from TMC Kolkata. And right now, we run an GI HPB unit here in CIHS Hospital, Dimapur.
Dimapur, fantastic. So I just wanted to ask you, Dr. Suraj, you've been in Delhi and you've been now in the Northeast. What is the disease profile as GI diseases are concerned? What is typical about the Northeast which you don't see in the North? I'm sure there are disease differences. What are your comments on that?
So the first take is when I was in AIMS, I didn't see much of chronic polyps,
Oh, wow.
like this chronic adenomas. I just did a few polypectomies when I was there in AIMS, but over here at my center, doing EMR is a routine thing on a daily basis for colonic polyps. And also we have
Suraj, sorry to interrupt you. That
yes,
may be because of an expertise, because your known people come to you more often, or do you think the incidence is higher?
the
You may be
incidence
the only
is
person doing in that area, so they'll come to you. What do you say to that?
no, I truly believe there's a difference mainly because of one is definitely genetic and one is because of the food pattern is very different.
Okay, that's
So
interesting. That's interesting. Okay.
yes,
What else?
yes,
What else is
yes,
different?
yes. So this is something like, colonic polyps are a major issue and this is something which you find on a daily basis. So
Okay,
this is
great.
very, very different, number
What
one.
else? What else is different?
So again, we have early gastric cancers as well.
Oh, great. Okay, that's interesting. That's interesting.
Yeah, so we often do endoscopic submucosal dissection for these early gastric cancers. People in the north are of the opinion that early gastric cancers are very, very few. But right from the start, I have been opposing this and I have proven in almost all the conferences that these do exist,
Okay.
especially in the Northeast.
So, Suraj, what is the difference in the incidence of various malignancies? What is the difference? You
In
have
terms of GI cancers?
GI cancers. Do you have a higher incidence of esophageal cancer or gallbladder cancer? What is it like in the north? We have a high incidence of gallbladder cancer, where if you go down south, Merin will agree that gallbladder cancer does not exist that much. So are there any difference in the cancers also in Northeast?
Yes, I've always said like if you this one we don't have anyone representing from Mizoram, but if you look at the entire prevalence of CS stomach in India, so Mizoram is number one.
Oh, really?
So the same population of Mizoram has got a spillover at this one, Manipur as well.
Okay.
Same racial background. So we have a high incidence of CS stomach.
Okay.
Colon cancer also is very high. And something atypical is we have a lot of nasopharyngeal cancers as well.
Yeah, that's head and neck cancer. Okay, that I understand.
Yes.
Okay, thanks.
Regarding CAGB and CA pancreas, I think those are pretty common as well.
Okay, thank you very much.
But something different in Northeast is NPC, nasopharyngeal carcinoma,
Okay.
and CA stomach and CA colon.
Thank you. Dr. Marin, what do you find the difference between the surgical profile? You've been down south, now you're in Northeast. What is the difference in the surgical profile of patients?
Yes, I'm sorry for that. So once I came back here, the lifestyle, the food habit is completely different. If we look at South, North, and Northeast, I think Suraj will also agree with it. It's completely different. We are so much into meat. So, I mean, like it's a daily food in our diet. So the meat with the smoked food makes it very high incidence of cancers, mostly the upper GIs. Like sir was mentioning.
That's okay, but I just want to know, that's okay. But how does it reflect into the GI surgery practice?
Yes,
That's
sir.
what I want to know from you.
Yes. So, sir, I have completed it's been 2 to 3 years since I've been working here in the GI unit. So for us, we do not have that much of screening and routine endoscopies. So for me, most of my patients, like let's say if I encounter a patient with esophagus or stomach cancer, they usually come with T4 stage. When I do a staging lab, it's usually the serocytes involved. Very rarely I have seen early gastric cancers in my setup.
Okay.
So, and yes, sir. And
sorry, go ahead.
and so regarding the hepatobiliary, we hardly see any cases here, the pancreas and gallbladder. Most of the cases which we do here are usually from the neighboring state, Assam. They come few patients from here.
What is your commonest surgery that you do apart from laparoscopic cholecystectomy and hernias? What is your commonest GI surgery that you do in your practice?
Sir, GI surgery wise, it's usually the colorectal, but most of our colorectal cases are emergency.
They come with obstruction?
Yes, sir.
So just now, since I have a perspective with you, so I will just the way, because this session that we are doing together is just to understand what is happening and what we are doing. So I will just slightly run through some things and then maybe I can have your inputs.
Yes,
So
just to interrupt, sir.
Say again, sorry, go ahead.
Just to interrupt, what is the prevalence of liver cancer in your setting? How many cirrhotics, how many percentage has got liver cancer?
We'll come to that. That's a good question. So I thought let's start from esophagus, right? Then we go in a system down and we work. Is it okay with you?
Yes.
So since we will not be able to give you the picture of incidence because we are a referral unit. So patients come to us all over. I will just tell you broadly about what is happening to have you an insight into the perspectives. So most esophageal cancers who come to us today, the treatment in nearly 90% of them based on a PET CT scan is to start them a neoadjuvant chemotherapy, radiotherapy. And then with the advent of robots, we are doing more and more of robotic esophagectomies with the anastomosis in the neck. And I agree, you'll agree with me that most of our patients, we've realized, are very malnourished. I'm sure in Northeast also they are malnourished. So nutrition is a very important thing. So we use many of them who have dysphagia and who are malnourished, who have to go for a preoperative chemotherapy. We use a gastroenterologist to put a stent sometimes so that they can eat, they can get better. And we are realizing the importance of nutrition in foregut cancers a lot. You agree with me that feeding is very important. Earlier surgeons, physicians, we never gave so much of importance to building up a patient's nutritional reserves to improve them. So we are doing a lot of that. And I think your patient, you say, eat a lot of meat. So I think they may be better nourished than people in the north. What do you think? So what do you think, Suraj? You've been in Delhi and you've been in Northeast.
Yes. Definitely better, I think.
Yeah,
Yes.
better nourished. I think better nourished. And because they eat meat, and though I think it, no matter what you say, animal proteins are more nutritious than plant proteins. So we used to earlier do some surgery for achalasia cardia, Suraj, but now you
Yes.
guys have taken over. So
Yes.
majority of patients want to get a poem done, and
Yes.
so we are doing lesser and lesser of the laparoscopic Heller's myotomy. And I agree with you that a poem is a good procedure. We can debate it, but definitely it's a less invasive and a better procedure, possibly than a surgery it is. You agree with me that it's a good procedure. Third space, you guys are getting better and better, so we are left behind. Do you get some patients who have corrosive injury in your that northeast or no? Very rare. Do you get some
Yeah,
corrosive?
in my setting, it's common.
Oh, really? Common.
Yes.
It's mainly suicidal or accidental.
Suicidal, 90%.
Oh, yeah, yeah. So when I used to work in a public hospital, that used to happen, but in private hospitals, it is much less happens. So you manage these patients mostly with dilatation,
Yes.
and there are good results.
Yes.
So, Dr. Meron, you get some esophageal. Is there a is PET scan easily available in the Northeast?
No, sir. Right now, PET scan is not easily available. We have to refer our patients to Guwahati, but it's on the way. Means our hospital, we are building up a PET scan setup that will be complete in another 6 to 8 months.
Do you have facilities for radiation and chemotherapy freely available?
Yes, sir. Of course, yes, sir.
That's a very good thing because we are beginning to realize that most gastrointestinal cancers will need preoperative chemotherapy and radiotherapy. Esophageal cancers, over 90% patients today will get that before they are taken up for surgery. So we do a reasonable bit of surgery, and most of our thoracic part is done robotically these days because it is more compliant with the patients and the over years, because we've specialized, some of us does esophageal surgery, some do gastric surgery, the overall results of the perioperative morbidity and mortality has significantly come down. And it's interesting that you say that you have a higher incidence of gastric cancer in your setup. So are majority of patients advanced by the time they present to you, Dr. Meron, or they are you can do a gastrectomy? What is the normal pattern of that?
Yes, sir. So I am actually doing a study right now. It's on the way. I mean, I will take another couple of years to complete that. So I just there was a prospective. I've just retrospectively collected some details of patients. And the last 5 years, there are around 700 patients who have got treatment from our hospital. But we also have patients who are coming from the eastern part of Assam. So it's not actually the local population alone. So we are trying to sort out, trying to
Oh,
find the incidents.
what is your commonest surgery you do for gastric cancer? Is it a subtotal gastrectomy or is it a total gastrectomy? What is it?
Yes, sir. So it's a subtotal gastrectomy. Most of our patients, they have distal gastric cancer and they come with obstruction. Most of them, almost 40% of them come with obstruction,
That's
gastric
not a
outlet
good thing.
obstruction.
That's not a good thing because
Yes.
if they come with obstruction, it means an advanced disease. And
Yes.
if you have a tumor in the G junction, I think you will agree with me that nearly all of them will need a preoperative treatment with the chemotherapy, oblique radiation, and then we take up with surgery. Do you do some laparoscopic surgery for gastric cancer?
Yes, sir. We do laparoscopic dido subtotal gastrectomy as well.
Very good, very good. Now, Dr. Suraj, uh, you said you have early gastric cancer. That's very interesting because most of us believe that it does not exist, but maybe patients come to you. Do they come to you with symptoms or do you screen them? How do they reach you? Does it happen?
So I try to actually search for it.
Okay,
I'm very much interested in image enhanced endoscopy, magnifying NBI.
okay.
So I screen patients who are above 50 years, family history,
Okay.
then H. pylori antigen positive, like who are smokers, and then I take a lot of time to screen these patients, and then
You look for that. You
this
search
is
for
this
that.
is mostly active screening,
Okay,
not
that's right. Very good.
mostly they present with dyspepsia.
I understand what you're saying. And I think also the incidence of smoking is very high. And then I'm told that in the Northeast, people consume some betel nut or something. That is also, am I right? They consume
Yes,
some,
of course. Yes.
and it causes a higher incidence of esophageal and gastric cancer. Is it right? Something like that?
So we don't have data on any studies on that yet.
Okay. But we
But
strongly, the biggest problem in gastric cancer is to detect whether the lymph nodes are involved or not, because that's the biggest bugbear. There is a lot of data emerging that even in resectable gastric cancer, possibly preoperative chemotherapy helps. So our biggest problem is that whenever we do a gastric cancer surgery, we always do a diagnostic laparoscopy before surgery. And many times the preoperative findings, the radiological findings don't match the intraoperative findings. Many times you find some peritoneal metastasis or things like that. So that's a bad prognostic sign. And there is a lot of interest these days in cytoreductive surgery and HIPEC. But our experience with cytoreductive surgery and HIPEC in gastric cancer is poor. That and literature also suggests it's too major a surgery, and these patients do not benefit much. Another lesson we learned was that when you have, that may be more of interest to the surgeons, that when you have a tumor in the fundus or something, then you have to do a total gastrectomy. Earlier we tried sometimes to do a partial thing, but the problem with that is that when you do a thing like that, the bile reflux is so high, it becomes so difficult to manage. So we nearly always end up doing a total gastrectomy, and many of these procedures are done by a minimal invasive technique. And the advantage of minimal invasive technique is that possibly the hospital stay in these patients may not be altered, but pain and all is significantly less. So that's what our experience is. I think surgeons today are getting more and more hooked on to minimally invasive procedures, and laparoscopy that way has come up in a big way. And we have learned also things that we used to do in the past, that keeping the patients nil orally for a long time, too many antibiotics, too many drains, too many tubes. We realized most of them does not work. So I believe, Dr. Moran, you also start feeding your patients early after surgery. So earlier, when I was a student, we used to keep Riles tube for 3 4 days, nil orally for 4 5 days, not moving patients. But now majority of our patients are started on oral fluids the next day and try to remove the tubes as early as possible. Is that the way you also do it there?
so for us, we put nasogastric tube NJ
Okay.
post procedure. So orally we start on after 48 hours. We
Yeah.
don't start immediately, but
Yeah.
yes.
Yeah. So I think gastric cancer is a disease, and what you said is very right. We all have realized that a D2 gastrectomy is essential because removal of lymph nodes is essential. It may not be of prognostic importance, and not of may not prolong life, but it's very important to stage the disease appropriately so that appropriate management can be given. You guys do tell me
Just
that.
to interrupt,
Yeah.
so in surgically resectable cases of CS stomach, do you always use a float regimen upfront before surgery?
Very good question. For G junction, yes, we'll always use a plot, and then we'll give 4 courses. Then we wait, we repeat a scan, and then we operate these patients. So you're very right. That's what we will use in these patients. So I'm so impressed with the gastroenterologists being so literate on that. So I think you guys do a lot of colonic cancers. So Suraj, what is the general distribution of colonic cancer? You get more right-sided, more left-sided. What is the general distribution in your setup?
So it's mostly left-sided.
Left-sided.
Yeah.
Maran, you agree with that? Mostly left-sided?
Yes, sir.
So you guys are lucky because we know now that left-sided colonic cancers biologically are better than right-sided colonic cancers. The long-term outcome of left-sided cancers are better. They are more chemo-responsive. They have less mucin producing. So the long-term outcome we know is better than left-sided cancers. So do these patients present mostly with bleeding, obstruction. What is the general pattern with which they present, Suraj? In your case, bleeding or obstruction or advanced stage, what is it like?
Yeah, we do get obstruction, but that's not very frequent. So most of these patients will present with either anemia or altered bowel habits. Mostly altered bowel habits, loss of appetite, weight loss. These are common ones.
I think that's you said a very sensible thing that I think in an elderly patient, if you have constipation or something happening, that's a very sinister sign. And another lesson I learned, you'll agree with me, Dr. Suraj, is that a man who's over 50, 55, who has bleeding per rectum, and you do a proctoscopy and you find piles, that's maybe a red herring. You should always do a colonoscopy. You agree that
Yes, 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 definitely.
many patients undergo hemorrhoidectomy, they continue to bleed because there's a cancer. Am I right? So I
Yes,
think
yes, yes.
anybody, elderly patient bleeding per rectum, a colonoscopy should be done. Do you agree with that?
Yes, definitely.
So that's another thing. So, Maureen, how do you do your colectomies? Are they laparoscopic? Are they open? What are your views about them? On the right side, did you do a right hemicolectomy? Majority of them are open or laparoscopic, or what is it like?
Yes, sir. For left colon sigmoid and rectal sigmoid, we do laparoscopically because it's easier for us.
That's very
But
good.
right colon, most of our cases, it will be like 80% open and 10 to 20%
That's the
laparoscopically.
same with us because the left side you have an advantage. You can do a stapled anastomosis and then you can do that. Suraj, I think one of the greatest role of a gastroenterologist to me today is somebody with a left-sided colonic cancer coming with obstruction. Earlier, we used to do a colostomy on that. That was terrible. You guys do a great job. You put a stent. Do you agree with me that a
Yes,
metallic
yes,
stent is the best way because it does not spoil surgery? There's no colostomy, and you can immediately start whatever you want to do. What are your views on that? Isn't SEMS a great thing?
yes, yes. For us, like putting stamps is a normal thing over here.
Very
A
good.
patient comes to obstruction, so we immediately put a stent, and then the job is done.
Problem with surgeons is they always have this funny argument that, oh, SEMS is expensive. Actually, SEMS is much cheaper than surgery because you put SEMS, there's no colostomy bag, there is nothing. You can do a laparoscopic surgery without any stoma after 2 weeks. It doesn't interfere with staging. Am I right? And it's so simple. So I think more and more surgeons have to be awakened to have a SEMS. But the problem is to get a skilled endoscopist like you everywhere is not possible. All centers do not have. So that's maybe an issue that how many gastroenterologists you think must be in that part of your country, Northeast? Trained gastroenterologists. Not many, no.
So over here we have about 9.
Okay.
My center has got 3.
Oh, three, you're a big center, then you're a big center. So, but
Yes.
that's the sad part, in one place there are 3, then in some places for miles together there is none. So that's a strange skewed phenomenon. Am I right? Maran, you have a gastroenterologist with you?
So we have our senior gastroenterologist. In fact, I don't know if it's a senior or a colleague of Dr. Suraj, Dr. Sedivi. He is also from AIMS.
Great.
And Dr. Talimo.
Sidevi is from CMC Valor.
TMC Valor, sorry. And
Ali is from AIMS.
Dr. Talimo, yes.
Yeah, much senior to me.
Okay, so now I have a question for you guys. Dr. Merin, what I'm asking you is this, that if you have a patient who's got a rectal cancer, so now you will nearly always need to give them preoperative chemotherapy, radiation. So you have facilities available around because nearly 90% of, my figure may be wrong, majority of rectal cancer you believe will need preoperative radiation. You agree? And
Yes,
then
sir.
they come up for surgery. So is radiation freely available there?
Yes, sir, of course. So yes, almost like you were mentioning, almost all of our patients we give neoadjuvant treatment for rectal and rectosigmoid. And we do have radiation chemotherapy. In fact, we have a big team of 3 of them who give radiation chemo.
That's a very good thing because I think now to operate a patient without preoperative radiation may be unethical because it significantly alters outcomes. So in radiation, so you will nearly always do a stoma in this patient. Am I right? If you do a low anterior resection or something, you will always do a stoma. Am I right?
Yes, sir. For all neoadjuvant cases, we do a diversion ileostomy. Yes, sir.
So what if I take you, there are say 10 patients of rectal cancer, how many of your patients will land up with an APR and how many will land up in LAR? Just I want to know your experience.
Yes.
In our setup, about 3 will land up with an APR, about 7 will be able to manage by an anterior resection. What's your
Yes.
figure like?
So almost similar like that only. In fact, we all have done, if it's a lower anal, a lower rectal or anal, we usually do go for an ELAP if it's a little advanced. But most of our cases,
Say it
we
again.
end up with NR.
Say it again. What did you lap APR? No, that's what you said. What do you say?
Yes, yes. ELAP, extra elevator
Oh,
sir.
that's ELAP. So
Yes, yes.
ELAP is ELAP in unit extended lap. You mean?
Yes, yes.
Oh well, I don't know. Does it benefit?
So actually, I was trained up like that. So yes, it's just I'm just at the beginning of my career, I should say, to come to a
So
conclusion.
because the data suggests that when you do that, take away the levator and eye from the origin, it leaves a big defect in the perineum. You
Yeah.
need a plastic surgeon to close it, and whether it benefits the patient is risk debatable. Anyway, so how are the stoma services in the Northeast? Do you have trained nurses or you manage it? What is the scene of the stoma appliances services in your setup?
Yes, sir. We have stoma nurse
You have?
who take,
Fantastic. That's
yes,
amazing. That's very amazing. If you have a stoma nurse, that's very good because you definitely need a stoma nurse to manage these patients because they are skilled and patients can interact with them more often. That's
yes.
important.
And it's a very easy job for us. We don't have to just look at it also. We just do everything.
So you are still a believer of when you do surgery, abdominal surgery, are you a believer of drains and what are your view on drains? You do drains in every patient or occasionally or selectively or never. What is your view on that?
Yes, sir. If I go for stomach cancer in subtotal, I routinely don't put in subtotal gastrectomies. In total gastrectomies, I definitely put. Rectal cancers post radiation, I put, sir.
Do you also, I may be wrong. Is the incidence of, Suraj, is the incidence of alcoholic pancreatitis higher in the Northeast?
Very much.
Okay.
Alcohol is consumed by almost
I didn't want to
70%
say
of the
it
population.
because I'm given this impression that alcohol consumption is higher in the Northeast. So
Very much, very
it's
much.
intuitive to say the incidence of pancreatitis would be higher also. Is it right?
Yes, yes, yes. Right now, I have around 3 to 4 patients of pancreatitis admitted at this moment.
Tell me a little bit about how do you manage these patients? There must be a lot of challenge, am I right?
See, like the only issue is with infected wound and this one, infected pseudocyst.
That's right.
So if it's in the approachable from the lesser side, I do a lot of hot exhaust placement. If it's mainly left paracolic gutter where I cannot access, then surgeon does a VAR, and then I do percutaneous endoscopic necrosectomy.
Following absolute the modern guidelines. So you have pushed the surgeon to the periphery in acute pancreatitis. Rarely needed, only when there's a complication. Majority of times you manage
Yes,
endoscopically. That makes sense also. And you'll agree that today majority of patients of acute pancreatitis who have collections or things can be managed by radiologically properly placed drains. The radiologists do a great job of doing percutaneous drainage. You agree with that? You have a good intervention radiologist there?
so we have a good IR, but the issue is like I'm not too for if it's too early in the course where I cannot see a capsule, then only
Yes.
IR guys come.
Oh, yes, yes. I agree with you. I agree with you. I mean, but that's right. That's a battle we keep going on. But what you said is a very golden words are yours that in acute pancreatitis, the later you intervene, the better it is. Am I right?
Yes, yes,
If you have to intervene in a patient in first 2-3 weeks, outcome is terrible because they
yes,
are bad. And the same, if you have to intervene after 6 weeks, no matter whether you do endoscopic or you radiological, most of these patients will do well. Am I right?
yes, 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 yes.
So, Moran, you also see some acute pancreatitis?
Yes, so it's like everyday admissions, but they are taken care by our gastroenterologist.
That's very good.
So I
But
get some referrals for this and all these things.
the problem of these patients is that patients who have severe acute pancreatitis, they demand lot of resources. Am I right, Suraj? You need to
Definitely.
ventilator, dialysis, feeding, parenteral nutrition. They have There are big, a lot of resources are needed to manage these patients. Am I right?
Yes, that's very correct.
You need a critical care person, intensivist, but the most heartening part of this disease is once they get well, then they are normal. Once they get well, they are normal. So that
It's very fruitful.
with the same theory, Dr. Suraj, you must be also getting a lot of patients of chronic pancreatitis also.
So we have more of acute pancreatitis. Chronic pancreatitis is not very common.
Isn't it strange? Because
Yes,
alcohol causes that also. Why does it
yes,
happen? Must be something genetic to do with it, right?
yes, 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 yes.
Smoking also very common in the Northeast.
Yes, I should say like smoking is pretty common. Smoking, alcohol is quite common.
Isn't it very interesting that you have a high incidence of acute pancreatitis, but alcohol is the leading cause of chronic pancreatitis? We don't get them. So that's many things about diseases we do not understand. Dr. Moran, you
Yes.
do some surgery for chronic pancreatitis or not?
No, no, sir.
Very little, very little, very little. So, and do you get what is the scene about pancreatic cancer, Dr. Suraj? What is about
Since I am the
pancreatic?
only one doing US and FNA, so I get so we have two big cancer centers over here.
Okay,
One is American Oncology Institute,
okay,
one is Carcinos.
okay,
So they send all their patients to me for FNA and for stenting.
okay.
So I should say like because my center sees most of the patients, I would say like it's quite common. It's a
Okay,
common thing over
but that
here.
may be a referral bias because
Yes.
you are the only one doing it. So, Dr. Meron, you do some surgery for pancreatic cancer?
Yes, sir. But not too common here, or maybe we are not getting the patients in to go elsewhere. That's also a possibility.
Yeah,
Yes,
that's a
and
very
yeah, we
logical.
do
That's a
we
very
do.
logical,
Yes.
very logical deduction that many of times these patients are referred. So we get a lot of referrals for pancreatic cancer, and that's one of our areas of expertise. So we do close to about over 100 pancreatic resections for pancreatic cancer every year. And many of them are borderline resectable. And earlier, we had a very pessimistic attitude about this disease. Now, with improvement in chemotherapy, we are resecting more and more patients with better CT scan, better preoperative staging. So, also, we are beginning to realize that in some subset of patients, preoperative chemotherapy may be helpful because it improves the results of surgery. So patients who have tumors in the uncinate process, we will nearly always give them preoperative chemotherapy, even if they are resectable. Earlier patients who had involvement of the superior mesenteric vein or abutment of superior mesenteric artery, we used to reject them. Now many of these patients get chemotherapy, and then we after chemotherapy we restage them, though the CT scan does not get altered, but in many of them we are able to do a resection following chemotherapy. So there is a significant improvement in chemotherapy in pancreatic cancer. The question you might ask me is long-term outcome altered? That will be difficult to answer, but the prevalent pessimism about pancreatic cancer is getting better. Of course, periampullary cancers are, they do better, and we will not routinely stent our patients. We only stent our patients by our gastroenterologist if these patients have a jaundice or they have cholangitis, or for some reason we have to postpone their surgery. That's when we will get them stented. So there's a lot of change in pancreatic cancer, and patients who have tumors in the body and tail of pancreas, majority of them, though, are unresectable, but the ones that we resect can be resected by a laparoscopic distal pancreatectomy and a splenectomy, which is a good operation. But the survival in pancreatic cancer, at least the short term, is gradually improving. Suraj, regarding your question about liver cancers, you get a lot of liver cancer there?
Yeah, so we did a study
Uh-huh.
and we found that the prevalence is about 14% in cirrhotics.
Oh, very
Yeah, it
high,
is a published data.
very high, no? So when you were in AIMS, what was the impression then at that time?
So like we have a dedicated liver cancer clinic, Dr. S.K. Acharya, So since I was with Dr. Acharya, we used
Okay.
to see a lot of this liver cancer cases, and then we do find a lot of patients coming from my state as well. So then I
Yes.
decided to study. Yeah,
That's right.
very
So,
high, very high.
so same is here also, I think. So we have an active liver transplant unit, and one of the greatest indications for them to do a transplant is a transplantable HCC. So I agree with you, but less than, I think, 10% of the patients who come are on non-cirrhotic livers. So 90% of the HCC we have is on cirrhotic liver. And do you get a lot of hyalocholangiomas there or no? Because in South India, I'm told that the incidence of hyalocholangiocarcinoma is high. In Delhi, our problem is gallbladder cancer. We see in a reasonable amount, and it's a bad disease because majority of times these patients are unresectable. Results of surgery are very poor. Only ones who do well are the ones who have an incidental gallbladder cancer. You do a cholecystectomy and the biopsy comes and shows that a cancer. So that's how it is. So there are a lot of questions people have put in the chat box regarding the questions. So one of the questions is that do the modern surgical techniques reduce the recovery time? I think we agree that laparoscopy decreases pain, and many of these patients can get back to their normal activities as compared to open surgery. Then people say, can I be able to eat normally after surgery? Yes. Mostly there are no diet restrictions after a surgery. So, Suraj, how often you have a meeting with your surgeons? Often collaborate, discuss, and I think
Yes,
one of the diseases in which you need to discuss very often is acute pancreatitis. You agree? Earlier, we
yes,
used
yes,
to
yes,
have discussion only in cancer, but I think acute pancreatitis is one disease in which you have to have a collaboration with your uh, uh, surgeon to discuss what is the best modality of
yes,
managing these patients.
yes, yes.
So, is robotic surgery more expensive than normal surgery? Yes, robotic surgery is a little more expensive than normal surgery because the disposables and costs are a little higher. Then there's a question is how soon can I start walking and eating after surgery? I think all of us, three of us will agree that the old concept of keeping patients nil orally for long is not scientific. We should start feeding the patients as early as possible and make them walk as early as possible. Dr. Merin, you agree with me?
Yes, of course. Yes.
And Suraj, you also agree that
Yes,
early feeding
this
helps.
is very, very important.
And Suraj, I want the audience to know a little bit about your inputs about gut microbiota. Just tell the audience will know how important is our gut microflora. You agree? It's extreme importance for gastroenterologists at least. It's we have not recognized its importance. It is so important. Am I right?
Yes, nowadays people are trying to link everything with gut microbiome.
Yeah.
But yeah, but we have very little evidence as of now, except for use in pseudomembranous colitis and say like IBD. Other than this, there's a lot of interest, but then we don't have enough evidence to actually manipulate gut microbiota for any kind of use as of now. But I think this is going to be interesting. So we'll love to like uh, the new evidence to come out as research is actively going in the street.
So we will agree that we may not have data, but now we are beginning to realize that things like smoking, bad diet, too many antibiotics, they affect our gut microbiome. And the common people should be advised not to pop pills without a surgeon or a physician telling them. People keep taking antibiotics. Somebody has loose motion, give antibiotics. So all these, they do not benefit them, but they harm the normal gut bacteria and they are harmful. Am I right that many patients, they believe that we don't prescribe them antibiotics? We have forgotten. I get phone calls from patients that you made my discharge slip, but you did not write any antibiotics. I said, you don't need antibiotics. People don't understand that antibiotics don't heal wounds. Am I right? And
Yes.
misuse antibiotics is rampant. I'm sure in your setup also rampant, People in the periphery write antibiotics like anything. What are your views, Dr. Meron, about you feel the same?
Yes, sir. We actually give just prophylactic antibiotics for most of our major surgery.
Yeah.
Unless there's a spillage or anything, we don't continue the antibiotics.
Suraj, you agree antibiotics are very misused?
Of course, sir,
Yes,
everywhere.
so one common scenario is like, people using antibiotics in the first week of pancreatitis,
Yes.
when actually is a cytokine storm. So in my practice, I don't use antibiotics in the first week of pancreatitis until and unless there is an extra pancreatic source of infection.
Agree, totally agree. Very well said. Or if you are planning some interventional procedure, then you need to do them.
Yes.
But you and me cannot do anything. By the time patients refer to us, they're already on imipenem. I'm there with you also. By the time they
Yes.
reach you, they already had antibiotics, and then the problem is too many antibiotics. They get fungal sepsis and one problem after the other. I don't know how we can change it in this country. That anybody who's got loose motions, the exam fluoroquinolone is taken. So I mean, that's why these drugs have become absolutely ineffective for the bacteria that we have. Am I right?
Yes, that's right.
That's very sad. So you have any burning questions you want to ask, you want to discuss? We have, I think, discussed most topics, and the essence is that collaboration between a physician and a surgeon and patient-driven decisions are most important. They should be involved in our decision making. So you want to ask me any questions, Suraj? Dr. Menon, you want to ask me any questions?
Yes, so one question I would like to address is in your cases of CA pancreas involving the uncinate process where it is resectable, but still you went for preoperative chemo. Have you actually looked into how many actually had a, like a decrease in stage and how many actually progressed? Because that's still resectable, and then if you wait for some time, not everything or not every CA pancreas involving uncinate may respond to the preoperative chemo.
I absolutely agree with you. You are absolutely right. It is just our hunch. We do not have any data on that. It is just based on the topography that since it's close to the superior mesenteric vein or all, and there are some centers in Europe which are routinely giving chemotherapy to every CA pancreas. There is a lot of data emerging that it results. So we uncinate process, if you ask me, I do not have any data on that. We have just started believing in that. But whether it's the standard of care, answer is no. It is just a belief that we are carrying. I am not able to answer that question. We are just starting to do that, but I don't have any scientific basis for that. There's no scientific basis. We read something and we realized because the topography is so close to the superior mesenteric vein and the artery, we thought it might be better to give. So that's what it is. But I agree with you. There is no proof on that. What else can we discuss? I think for people who are going to be listeners, if there any other topic we need to discuss, I think for a surgeon, having a competent gastroenterologist is God sent. It's such a great collaboration between the surgeon and a gastroenterologist that we cannot function without you guys. Because if you see, there are some procedures which thankfully have gone out of surgical practice, like CBD stones. We rarely operate CBD stones. You guys are so good. Most, I think 95%, 97% of CBD stones can be managed endoscopically. Am I right, Suraj?
Yes,
So,
definitely.
So why do this? So we will have a CBD stone. We'll always ask our gastroenterologist to preoperatively clear the bile duct. And then we do a laparoscopic cholecystectomy. It makes so much of sense. It's so easy for the patient. So I think gastroenterologists have a great contribution. You have a cholecystectomy done. There's a bile leak. If it's a cystic duct stump blowout, you put a stent. Patient gets well in 48 hours. Right? So
Yes.
these things are so important. Collaboration, realization when surgery is indicated, when endoscopy is indicated. That's where when I was young, we used to do so much of surgery for variceal bleed. We used to do devascularization. We used to do emergency shunts. We rarely do a devascularization. I haven't done a devascularization in last 2 years. We occasionally do a shunt now. Elective ones we do sometimes, very rare, DHPV and all. But the sclerotherapy or the band ligation, tips, everything has come up in a big way. The profile has changed. Am I right, Suraj?
Yes.
What do you think, Meron? When did you last do a shunt? A renal shunt?
Never done, sir.
See, when I was a student, we used to do them so often. So times have changed. So because the intervention, gastroenterology has become so good. So that's what we used to do. Is there any other topic we haven't discussed, you think? Meron, you want to ask a question or something?
I have a couple of questions. This is in the same question as Suraj sir was asking regarding neoadjuvant chemotherapy for resectable pancreatic cancers. Sir, apart from all this tumor response and the prognosis, does the surgery becomes easier for you? That's why you give neoadjuvant, or it has nothing to do with
No,
that?
no. Surgery doesn't become easier. Surgery remains the same. If you give radiation, people believe the pancreas gets hard and less drained, but surgery doesn't become easy or difficult. It remains the same. The chemotherapy data is just to increase the long-term survival. Whether it does it or not, it is just like the political slogan that "अच्छे दिन आने वाले हैं." पता नहीं कब आएंगे, we don't know, but there's a hope in that. So that's my answer to the question. Though there's a lot of data suggestive of improvement, but it's still not conclusive. That's my answer to this. What else do you want to ask?
One more question. In the starting of the session, you were mentioning about stenting for C8 esophagus before we give a neoadjuvant treatment. Is it routine? Because for us, we
Not
just
routine.
put
Oh, no, not routine. No. Some patients, because what happens is, what we have forgotten as surgeons, as physicians, is that nutrition is a very important parameter, right? Now, CA pancreas, CA rectum, and CA esophagus are three diseases in which you have 4 to 6, 8 weeks before surgery is done, right? Now, in that time, if the patient can eat well, it significantly improves outcomes. If a patient can take liquid diet, we will not put a stent. No. In some patients who cannot even take liquids, in them we will get a stent placed. But putting a Ryle's tube for 6 weeks is very difficult.
we usually we put Ryle's tube. We don't stent the patients routinely.
So 6 weeks Ryle's tube is very difficult, Maran. Is that what
Sir,
do you think?
most of them, yes, sir, I agree with that. Most of them, if you respond well to the chemotherapy, by 3 weeks, they start taking orally.
I have a belief that you may be right, but even for 3 weeks, putting a Ryle's tube is
Yes.
kind of, that's what do you think, Suraj? What's your view?
No, we don't put Ryle's tube until unless patient cannot afford.
Yeah.
Mostly
I'm not saying all. I think
and then it's a fundamental right of every human being to be able to.
No, our view is that
Yes.
we should feed these patients, whether you feed by nasogingal
Yes.
tube, Ryle's tube, stent, orally. Nutrition should not be forgotten. It's something we have forgotten over a period of time. That's what I was wanting to say. So, and we should be aware that sarcopenia is a very poor predictor of long-term outcome, toleration to chemotherapy, results of surgery, surgical site infections, ventilator stay, ICU stay, right? So all these things, if you have well-nourished patients, their results of surgery are better. Is there anything else we need to discuss? I think we have nearly covered a broad spectrum of the problems and the challenges faced in gastroenterology and GI surgery. Suraj, sorry, it's surgically based because I'm a surgeon, so my bias is towards surgery.
Always learning.
No, yeah, that's the mutual. Is it okay? Can we finish? Thank you so much for being here. We absolutely enjoyed. And let me check if there are any questions left in the chat box so we can answer. We eat normally, elderly patients. Yes, we all agree age is no contraindication to anything. Am I right, Suraj? It's the physiological age of a patient. Chronological age is not important. So it's the physiological. Am I right? You will do a hemicrectomy in a 90-year-old man also with fit. Am I right, Suraj? You will do anything you want.
Yes.
So that's what we do. I think nearly answered all the questions. Yes. One question is minimal invasive surgery possible if I had previous abdominal surgery? Yes, it's possible. We always attempt. Am I right? A previous surgery is not a contraindication to minimal invasive surgery. Can advanced surgery reduce the risk of infection? No, advanced surgery cannot reduce the risk of infection. Is an independent prognostic marker. So I think we are nearly done with everything. Thank you, you guys. You were great. Suraj, you were great. Dr. Meron, you were great. Thank you so much for your time. And I think we had a meaningful session.